minimal invasive rhinoplasty. I'm Dr. Xu Xinjian. I'm Taipei City Hospital from Taiwan. And let me introduce the first speaker, Dr.邱正宏. He is a famous otolaryngologist, specialized in facial plastic surgery, fat grafting, and body sculpturing. And he graduated from Yangming Medical University. Yeah, he also published many journals, so he's a worldwide famous doctor. Today, he will share his topic on technique for injection rhinoplasty. Let's welcome Dr. Cho.
Thank you. Thank you, Dr. Shi, for your kind introduction, and thank you everybody here for still being here, for listening to my speech. I'm Dr. Cho from Taiwan. My topic is advanced techniques for injection rhinoplasty. I declare no conflicts of interest regarding the content of this speech. As you all know that rhinoplasty is a common surgical procedure in many countries of the world. According to ASPS, rhinoplasty is the third most common surgical procedure in 2017. Non-surgical rhinoplasty offers a quick, cost-effective treatment with no downtime if proper filler is injected judiciously. So it is important that facial plastic surgeons are familiar with filler placement in the nose. Among the multitudes of fillers, hyaluronic acid injection is a valuable tool for minimally invasive nasal reshaping and has the advantage of being reversible with hyaluronidase. However, retreatment may be needed to maintain the desired aesthetic correction because hyaluronic acid degrades over time. So in this presentation, I will present my experience in non-surgical rhinoplasty with filler injection, provide an overview of the relevant nasovascular anatomy, discuss safety considerations, and review both basic and advanced techniques. An intimate knowledge of nasal anatomy is crucial to the safe practice of injection rhinoplasty. The framework of the nose consists of 5 layers of soft tissue overlying the perichondrium or periosteum, which are the epidermis, dermis, superficial fatty layer, fibromuscular layer, and the deep fatty layer. The fibromuscular layer is the continuation of the superficial muscular aponeurotic system. And the main arteries of the nasal dorsum are located at the level of the superficial or deep fatty layer. The vascular network of the nose originates from both the external and the internal carotid arteries via the facial artery and ophthalmic artery respectively. The internal carotid artery gives rise to the ophthalmic artery, which then branches into the dorsal nasal artery, and anastomosis with the arteries originating from the external carotid artery over the nose. To simplify the arterial supply to the nose, a polygonal system based on 4 transfacial arcades can be used based on sebum and its colleagues. The intercarotid anastomosis of the angular and the dorsal arteries provides the vertical systems with the radius lateral nasal, marginal, and the subnasal artery, providing the horizontal or transfacial anastomosis, as you can see here in the picture. At the lower portion of the nasal dorsum, the dorsal nasal artery branches are located adjacent the fibromuscular layer and the deep fatty layer, meaning that in this area, the dorsal nasal artery runs deeper. On the other hand, at the upper portion of the nasal dorsum, the dorsal nasal artery runs at the level of the superficial fatty layer, just above the fibromuscular layer, meaning that in this area, this artery runs more superficial. So for nasal tip injections, it was done using the compact sharp needle. Intradermal or subdermal injection in nasal tip was advised to avoid inadvertent injection into the vessels. On the other hand, for the injection in lower dorsum, a blunt 21 to 23G cannula was favored. Supraperichondrium or supraperiosteum injection was performed. So it is recommended to keep the injection along the midline with surgeon's fingers along the nasal side walls. This technique can keep the product in the midline. A multitude of fillers have been available in the nose, including hyaluronic acid, calcium, hydroxyapatite, and so on. The safety and efficacy profiles of lidocaine containing hyaluronic acid gels are similar to those of corresponding products without lidocaine. In my experience, hyaluronic acid injection is a valuable tool for minimally invasive nasal reshaping and has the advantage of being reversible with hyaluronidase. When performing non-surgical rhinoplasty, surgeons should think of cartilage grafts rather than simply contour. On the dorsum, filler placement is an alternative to surgical diced cartilage placement. Patients with a low dorsum, most typically those of Asian patients, often desire a taller, narrower appearing dorsum. The smoothness and ease of filler placement may make this an attractive alternative. In patients with a low dorsum, it is important to consider the natural starting point, typically at the mid-pupillary line for most Asian patients. This 26-year-old female underwent hyaluronic acid injection to increase the height of nasal dorsum, tip projection, and for lengthening the nose. A total of 2 cc hyaluronic acid was placed at the dorsum, nasal tip, columella, and the posterior nasal spine. She was very happy with the result at 6 months after the operation. To fill the dorsum, one may use a cannula with the bevel facing downward to the perichondrium or periosteum. I prefer introducing the cannula 3 radix rather than the nasal tip. The cannula tip should be kept below the level of the nasion. In most patients, 0.4 to 0.6 cc of filler is enough to provide enough dorsal height, depending on the native height and the desired effect. This 31-year-old patient presented for the correction of low dorsum and sunken tear troughs. 1 cc of hyaluronic acid was injected to the nose and 0.5 cc per side to tear troughs were performed. She was happy with the results. Basic techniques: camouflaging a hump. Reduction of the nasal hump is seldom requested in Asian patients, as most patients do not have a large hump and mistakenly regard the nasal hump as high dorsum. So filler placement can be a good option to camouflage the hump and simultaneously increase the dorsum height if a low radix is present. Placement of filler above and below the hump is a simple maneuver. Similar to dorsum augmentations, the natural nasal starting point must be assessed, And distally, some patients desire a supratip break, whereas others prefer a straight dorsum. This 18-year-old patient presented for the correction of a minor hump over her dorsum and reduction of her bullous tip. A total of 0.2 cc hyaluronic acid was injected along her nasal dorsum, above and below the hump. 0.15 cc of hyaluronic acid was injected intradermally at her bullous tip to contour the bullous tip, as you can see here. And this patient was happy with the result. Advanced techniques. These maneuvers require deeper consideration of the safety factors previously discussed, including injection depth and vascular anatomy. Advanced techniques can be performed to achieve the results similar to that from nasal surgery. Atopic nose, advanced techniques for tip rotation. Atopic nose tip can cause an aged appearance. In addition, if the tip is ptotic, feminine noses may appear more masculine. The tripod theory is well known, in which each lateral cross represents one leg of the tripod, whereas the paired medial crural represents the third. This theory can also be used when it comes to filler injection. The medial crural leg of the tripod can be effectively lengthened with filler placement under the base of the medial crural. The filler is introduced from an anterior approach directly at the base of the columella. The filler is placed deep near the posterior septal triangle to avoid injection into the columella artery. It's important. The amount of filler should not exceed 0.2 cc to avoid compromising the external valve and widening the columella base. This 50-year-old patient underwent traditional rhinoplasty with L-shaped silicone implant 2 decades ago. Revision rhinoplasty was performed 5 years ago to correct the problems after silicone rhinoplasty. However, after revision rhinoplasty, she was still unhappy with the result. Undesirable appearance of her nose was complained of. She presented for a better tip rotation. However, during the injection, rigid and fibrotic subcutaneous tissue was noted over her nasal tip. So hyaluronic acid was injected at columella base, posterior septal triangle, and the caudal septum instead of nasal tip. You can see here the results was immediate and was optimal. She was very happy with the result. Filler placement at the tip is achieved by placing 0.1 to 0.15 cc of filler in front of the tip defining points, precisely in the midline. The optimal approach is from an entry point in the infra tip using a 29 gauge needle. The skin and soft tissue envelope can be tented up to reduce the risk of intravascular injection. Of course, aspiration before injection is important to avoid vascular compromise. If desired, the infra tip can be slightly lengthened using this technique as well. This 20-year-old patient presented for a higher dorsum and a better tip definition. So for tip projection increment, a total of 2 cc hyaluronic acid was injected to the dorsum, nasal tip, columella, posterior nasal spine to increase her dorsum height, tip projection, and rotation. The nasal labial angle was aesthetically more pleasing after the injection as well. She was happy with the result, even 2 years after the operation. Advanced techniques are straightening the nose. Straightening the nose with filler is quite straightforward. Deviation of the nose can occur at the upper dorsum, lower dorsum, and the tip. and often some combination of all three. The filler can be placed on the concave side of the middle board, functioning as a spreader graft. Advanced techniques for lowering alar rims. Filler can be placed along the alar rim, achieving some of the sun effects as a rim graft. The filler is introduced laterally with a 29-gauge needle. When in the upper plane, the needle moves forward relatively effortlessly. Injecting the filler intradermally here is safer in this area. So in conclusion, the optimal approach to non-surgical rhinoplasty necessitates thinking in terms of grafts rather than just contour changes. For tip reshaping, intradermal or subdermal injection with needle is advised. For dorsal contouring, supraperichondrium or supraperiosteum injection with fine cannula is suggested. Non-surgical rhinoplasty can help build confidence in the patients and provide them an opportunity to foresee their new nose several months or years before surgical rhinoplasty. The ability to smooth minor nasal contour can help to reduce the likelihood of revision rhinoplasty and its associated expenses, risks, and downtime. Thank you for your attention.
Thank you, Dr. Chou's presentation. And is there any question?
Yes.
How did you do the injection from the radius and have a straight line injection?
No, I used cannula, and before injection, I bent the cannula to a curved shape, then puncture with a needle, and introduce the cannula along the nasal dorsum. So it's easy to perform this injection.
What do you think is better?
Oh yes, because usually my patients requested to correct the nasal tip shape, include increase tip projection or rotation. If you puncture nasal tip here, then the hyaluronic acid will leak out once the pressure inside the nasal tip increase. That's why I don't puncture over nasal tip. Yeah, in this way you can inject more hyaluronic acid in nasal tip and make more correction here. Any further question? Thank you.
Okay. Thank you, Dr. Chou. Because of limited of time, let's the second speaker. Because it's pity that he can't attend our meeting, so he will show.
各位朋友，如果你喜欢我们今天所讲的，请在下面按个赞。如果你对我们的内容感到兴趣，想要获得最新的讯息，请按订阅。下回见。